Uh-huh. Yes, I am muted now. Unmuted, yes. Mhm.
Hello, we will start in 5 minutes.
Taip, laba diena, good afternoon. Is somebody is hearing me?
Yes.
Yes, we hear.
So, unfortunately, I do not have a program of the conference. Who will be announce the presentations? I see that.
Hello, I had the list of presentations, so I can announce the first speaker if we can start.
We will have a session moderator, and she will be announcing the.
Okay. Okay.
Welcome everyone to the 5th International Health Science Conference Internal Medicine Session Part 1. My name is Ustea and I will be leading this session today. First of all, on behalf of the Student Scientific Society of Lithuanian University of Health Sciences, I would like to thank our sponsors, Fresenius Kabi, Ambos, Medaxa, Origumed, Meditecha, Optometria Centers, our Mama, and for helping us organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedicine fields. We hope that International Health Sciences Conference will help to build friendly and professional relationships and share experience in fundamental medicine, biomedicine, dentistry, pharmacy, and public health with young scientists all over the world. Also, I would like to express gratitude to all of the reviewers and today's jury. Professor Juozas Kupčinskas, Rūta Navardauskaitė, Dr. Ida Liseckienė, Professor Limas Kupčinskas. Before starting the session, I would like to remind you some rules. Today we will hear 8 presentations. All of the presentations will be evaluated by the jury. Based on the average scores given by the jury, we will choose one winner from the section. The winner will get an amazing concert of 50 coupon for medical clothing, 25 euro bookstore coupon, Ambo subscription, glass for computer work, and other marvelous prize. We will contact you within 2 weeks from the conference. Moreover, presentation should last no more 7 minutes, and after that, 2 minutes will be dedicated for juries and listeners' questions and remarks. If your presentation will take more than 7 minutes, you will be asked to go to the final slide and finish your presentation. I ask the jury to fit in time as well. In addition, you will receive your certificate for presenting your abstracts to your emails after the conference. Do you have any questions before starting? So best of luck to all the presenting authors. So now I would like to invite the first presenter to give us the first presentation, the morphological patterns of immune neurons in women with celiac disease.
Hello, everyone. My name is Kaius Merkevičius, and today I will be presenting our research about the morphological patterns of the immune response in cases with celiac disease. One second. The celiac disease is described as the serological and morphological changes in individuals who consume gluten, and in most cases, this disease develops in genetically predisposed individuals, meaning that there is specific genes or gene combinations and their mutation associated with this disease. Worldwide, around 1% of population is affected by the disease, but the number of cases is rising worldwide as well. For example, in the United States of America, the abundance of this disease increased 4 times. Here in Europe, for example, in Finland, in the last 20 years, the number of cases have doubled. And here in Lithuania, we have data since 2001, and the data shows that the number of cases yearly is rising as well. The pathophysiology of the disease is very complex. Both naive and acquired immune response are responsible for structural and other changes in individuals. However, emerging research suggests that other factors like stroma cells, intestinal microbiome is at play as well. Thus, it is no surprise that clinical manifestation, serology, and morphological changes are heterogeneous as well. In this research, we aim to evaluate the morphological patterns of immune response in gluten enteropathy cases. We included cases of gluten enteropathy that were diagnosed in the Department of Pathology, and morphological changes were evaluated in MARCH classification, which is used worldwide since early 2000s. And several updates and modifications have been proposed over the years, but they all share the same criteria, which are intraepithelial lymphocyte count, cryptohyperplasia, and polyatrophy. Intraepithelial lymphocytic infiltration was evaluated as count per 100 enterocytes. Eosinophilic granulocytes were counted per 1 high-power magnification field, and in this research we evaluated patient gender and age as well. A total of 193 cases with the average of 41 years old was included. And here in the chart, you can see that type 1 gluten enteropathy is the most common type of gluten enteropathy among included cases. No difference was found between the two genders. Here is an example of two of the most common cases, type 1 and type 3 gluten enteropathy. Here in type 1 gluten enteropathy, we can see a normal duodenal tissue with increased intraepithelial lymphocytes, while in type 3 gluten enteropathy, we see alongside intraepithelial lymphocytes increased hyperplasia and mild willy atrophy. We count the intraepithelial lymphocytes, and it was we noted that there was a marked variability in each case from the lowest and the highest number of intraepithelial lymphocytes. Type 3B and type 3C had no variability. However, we only included several several cases with these types of gluten enteropathy. Thus, we think that this part of the data is not representative. Interestingly, the lowest count of intraepithelial lymphocytes was significantly higher in type 3A type compared to type 1 cases. There was no difference between male and female patients, but younger patients had a significantly highest amount of intraepithelial lymphocytes. Eosinophilic granulocytes were found in more than half of cases, and on average, we counted 7 eosinophilic granulocytes per 1 eye magnification field. Here in the picture, you can see 6 eosinophilic granulocytes, and we found no difference among marsh types or the 2 genders. However, interestingly, we found that the younger patients were more likely to be infiltrated. The tissue from younger patients was more likely to be infiltrated by eosinophilic granulocytes, and furthermore, the amount of these cells was significantly higher in younger patients as well. To summarize, lymphocytic count in dermal biopsies was significantly higher in type 3A gluten enteropathy and in the younger patients, and infiltration of eosinophilic granulocytes was present in more cases, and once again, it was more common among younger patients, and they had a more extensive infiltration compared to older subjects. Thank you.
Thank you for your presentation. I would like to ask the jury if anyone has questions.
Hi, thank you for the nice presentation. I have one question. How can you explain a higher count of lymphocytes in type 3A celiac disease than compared to type 3B and 3C? What is the reason for this? What do you think?
Thank you for the question. I think that it is related to continuous consumption of gluten, because the marsh types represent the continuous damage to the small intestine, while the person continues to use gluten in his or her diet. So as the immune system reacts to the gluten and he or she continues to consume it, the response from immune system does not how to pronounce it does not go mild. It only stimulates other parts of the immune system. For example, the first reaction is non-specific and cytotoxic. Later on, while the person consumes gluten even more, then autoimmunity starts. So I think that is why it is related to the higher number of lymphocytes. However, our data wasn't representative enough because we didn't have enough cases of type 3B and type 3C to see if the trend continues. So I think that would be.
Thank you.
Again, thank you for the presentation, and let's move on to the second presentation of our session, ligation of esophageal varices, repeated ligation, short-term treatment outcomes, survival rates, and complications.
Hi, can you hear me?
Yes.
Okay, thank you. So, hi, my name is Antanas Dombrauskas, and it's really nice to be here in this conference and to see a lot of well-known faces in the research society. It's really honored to be here, and I want to present the ligation of esophageal varices, repeated ligation, short-term treatment outcomes, survival rates, and complications. So we made this research during this year, and it was quite difficult due to the circumstances of COVID infection, but still we are happy to present you the research that we have. And so according to prospective research, all of the cases of esophageal varices are formed due to hepatic cirrhosis, and the bleeding from esophageal varices is one of the most dangerous complications of all. And about 1/3 of all patients have complications associated with bleeding, and mortality rate can reach up to 30 or even 50%. So endoscopic variceal band ligation is indicated as a primary prophylaxis in patients with medium or large esophageal varices and a high risk of bleeding. So, and of course, repeat endoscopy is recommended every 3 to 6 months. And the aim of our study, the procedure is performed with a multiple band ligating device. So just to be short, the endoscopist makes the contact between the end of ligating device and varix, and then the endoscopic suction draws the varix into the device, and then the elastic band is ejected to ensure the varix, and the ligated tissue slots after 3 to 5 days, and the ulceration that is generated during the contact generally heals within 1 week. And I wanted to show a little bit of pictures related to the procedure itself. So as you can see in the picture A, there is a varices before banding, and in the picture B is a esophageal varices post banding. There's also the classification of the esophageal varices. So as you can see here in this table, there are small, medium, and large grade varices, F1, F2, and F3. And as you can see in these pictures, in picture A, you can see small sized varices, in B, the medium sized varices, and in 3, there's a large sized varices. And the aim of our study was to evaluate short-term treatment outcomes, survival rates, repeated ligations, and development complications for patients who had subjected to endoscopic band ligation at Lithuanian University of Health Science Hospital, Kauno Klinikos, Department of Gastroenterology. And we did a retrospective analysis with patients who underwent ABL in 2015 and 2019. So the results, we analyzed the 131 cases. In 34 patients, the repeat ligation within 6 weeks was performed, and the average year of the patients was 49. As you can see in this pie chart, almost half patient was men, and the other half was men. Talking about epidemiology, as you can see from the chart below, the 2 main causes for the esophageal varices in our population were hepatitis C and the cirrhosis associated with hepatitis C, and also the carcinogenic cirrhosis. as I mentioned before, there are 3 grades of the esophageal viruses, and in our population, the biggest number, 52.67%, had F2 grade viruses. What was interesting that 41.98% had F3 viruses, and only 5% had F1. Indications for the procedure were primary prophylaxis, second prophylaxis, and bleeding. Primary is when patient not encountered band ligation before. The secondary prophylaxis was when the patient had episodes of bleeding, and it was used to prevent from bleeding. And the bleeding indication was when the doctor need to stop the active bleeding from the viruses. And you can see the proportion of the patients are almost equals in this category. Complications were associated and significantly correlated with esophageal viruses grade. As you can see in this chart, the main complication was rebleeding, and also what's interesting that the death that the complication associated with F3 grade viruses was death, and other complications were not so expressed. And to conclude our topic, like I mentioned before, bleeding correlated with esophageal viruses grade, and the most common complications after procedure were fever, stenocardia, pathology of esophagus, but the frequency of those complications was very low and did not affect the patient's short-time condition. Short-time condition is 6 weeks after the procedure. The death rate after band ligation was 9.28%, which is quite low. Complications in patient death significantly correlated with esophageal viruses grade, like I mentioned before. So thank you for listening to my presentation, and I would like to hear some questions.
Thank you for the presentation. I would like to ask the jury if anyone has questions.
Hello, do you hear me? Antanas, can you hear me? Yes.
Yeah, yes, of course.
So thank you for your presentation. Maybe the slides were very clear, but maybe for future, I would like to wish you maybe to make them shorter so you don't have to rush. Maybe it was, okay, of course, extra of adrenaline, but this is a small suggestion. And I would like to ask, what was your personal input in this action, and did you have a chance to see the procedure itself?
Yeah, I witnessed the procedure a couple of times, but my impact was I went to the department of the gastroenterology, and I did I analyzed the history of the patient and entered it to the computer, and also did the statistical part. So that was the main part that I did.
Thank you
very much.
Again, thank you for the presentation, and let's move on to the second presentation of our session, factors influencing gastroesophageal reflux disease and their treatment.
So, hi again, and I'm going to present this topic again. We did 2 topics because this topic we prepared it for the last year conference, but due to the COVID, we couldn't present it. So I'm presenting it this year. So this was a bit shorter study, and it was like more simple in my opinion. The factors influencing GERD and their treatment. Gastroesophageal reflux disease is a condition when the reflux is causing uncomfortable symptoms such as heartburn and/or acid backflow, additionally to an injury of mucosal integrity for not less than 1 week. And as you know, there are several common risk factors associated with GERD, for example, smoking, obesity, stressful lifestyle, and irregular eating habits. So the aim of our study was to identify if those factors are really influencing the development of GERD, and what kind of treatment is the treatment that was prescribed was efficient to treat those symptoms. So we did a survey with 81 patients diagnosed with GERD, and I also want to mention that those patients were treated with proton pump inhibitors for 2 weeks, not less than 2 weeks. We assessed, in the survey, we assessed gender, body mass index, smoking history, eating habits, alcohol, coffee consumption, severity of symptoms with prescribed treatment, and in analysis we used chi-square test, primary coefficient, to compare qualitative data between groups. Moving on to the results, as you can see in these pie charts, the gender of our population was divided almost by half. It was 56% women and 44% men. As you can see in the next pie chart, that almost 2/3 of patients had overweight and class 1 obesity. So we can see that the population in general was quite obese. Moving on, 67.9% of the patients had irregular eating habits, and almost half of the patients, 48.1%, had snacks 3-4 times per day. Talking about other risk factors like smoking and stress, almost 40% of our population was non-smokers, and the vast majority of the patients, 54.3%, encountered stress frequently, which means once a day. So talking about alcohol and coffee consumption, 66.7% drank coffee each day, and 33.3% did not use coffee at all. Alcohol consumption, as you can see, the vast majority of our population used alcohol during celebrations, 63%. And 27.2% used alcohol once per day. And we also evaluated the symptoms which was still noticed even when the treatment was prescribed. So 58% of our patients still noticed some kind of symptoms, even if they were like really low and really unnoticeable so much, but they still in the survey they still answered that they noticed some kind of symptoms even with treatment, and 29.7% told us that they don't feel any symptoms at all. So we checked the correlation between factors influencing GERD and the symptoms. So as you can see in this slide, alcohol consumption and dysphagia, alcohol consumption and heartburn, irregular eating habits and heartburn, taste of sour or bitter and smoking, obesity and dysphagia, and duration of proton pump inhibitors usage and heartburn and regurgitation correlated significantly. So we made the conclusions. that the main factors of the appearance of GERD are alcohol consumption, obesity, smoking, and irregular eating habits. And the treatment with proton pump inhibitors for 2 weeks or longer was an effective way to reduce some kind of symptoms like heartburn and acid regurgitation. So that's all about this short study, and that's it. Thank you for your time, and I hope you have some questions.
Thank you for the presentation. I would like to ask the jury if anyone has questions.
I have one question regarding your statistical analysis. Did you perform analysis, or were you analyzing separate risk factors because they're interlinked?
Sorry, can you repeat the question? I didn't hear it completely.
Did you perform multifactorial analysis when you analyzed risk factors, or was it based on just one risk factor?
No, it was a one risk factor and a symptom. We didn't do multivariate analysis.
Okay. Thank you.
Hello again, Montanas. And I have a question. I think, but I missed the instruments you were using. For example, how did you measure stress and alcohol consumption? What kind of instruments?
So we did the survey. In the survey, there was a question about the alcohol consumption and the stressful lifestyle. We asked how the patients feel, and that's it. We asked if they feel stressed or no. Did they feel the stress frequently or no? And that's it. It was a survey. Sorry, I cannot hear you.
This is very important and common, often topic when you have to ask about stress, alcohol, risk factors. So there are a lot of questions already implemented. So you can in future use already implemented and validated questionnaires, so you don't have to do it by yourself. And another question, I'm a family physician, and it's very common problem in our primary healthcare level. How you recommend for patients what we can change the habits, how we can work with it?
So I think also my friends and other family members also ask me sometimes about the reflux, and I will say always that you first need to change your lifestyle from yourself. There is no treatment. Sometimes there is no treatment good enough to treat some kind of symptoms. So you need to change the lifestyle, find your own factors which improves the GERD symptoms, and also change your lifestyle from the basics, because there sometimes the treatment could not help, and then the patient feels that the physician doesn't do anything, or the physician is bad, but that's not the case. I think the case is when the patient doesn't work with himself.
I also agree with you that this is a place for lifestyle medicine specialists to work with such type of patients. Firstly, thank you.
Thank you very much for questions.
Again, thank you for the presentation. Jury, please don't forget to evaluate presentation in Judgify. So let's move on to the next presentation, the regulatory role of microRNAs in intestinal epithelial barrier and inflammatory bowel disease. Okay, let's move on to the next presentation, relations of physical activity and sleep quality in patients with type 2 diabetes mellitus.
So, hello everyone. Do you hear me?
Yes.
And now I'm going to share my presentation. It's nice to meet you. And our topic is relations of physical activity and sleep quality in patients with type 2 diabetes mellitus. And my co-authors are Karolina Krikščiūnaitė and Dr. Lina Lašaitė. And type 2 diabetes mellitus and its complications strongly impact patients' quality of life, daily activities, and psychological status. Sleep disturbances are related to chronic metabolic diseases, and the incidence of sleep disturbances in patients with type 2 diabetes mellitus amounts to 25%. Regular and sufficient physical activity inhibits the development of invalidating diabetic complications, and by this way improves the quality of life and prolongs life's duration. Physical activity may be related to sleep duration and sleep quality, and the aim of our study was to detect possible relations between physical activity and sleep quality in patients with type 2 diabetes mellitus. The research was performed in the Clinic of Endocrinology of Lithuanian University of Health Sciences Hospital Kaunas Clinic, and the permission to do this research was obtained from the Bioethics Center at Lithuanian University of Health Sciences. 49 patients with type 2 diabetes mellitus agreed to participate in the study, 25 men and 24 women. The inclusion criteria were age more than 18 years, absence of functional disabilities which limit mobility, and agreement of the patient to participate in the study. Data about diabetes and metabolic state were taken from the medical records of the participants, and the statistical analysis was made using IBM SPSS statistics software. The adapted Lithuanian version of the Pittsburgh Sleep Quality Index, or Pittsburgh miego kokybės skalė, was used to evaluate the quality of sleep of the participants. The main domains of sleep quality were evaluated: subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, sleep disturbances, use of sleeping medications, and daytime dysfunction. Participants were asked to answer the questions upon the events of the last month, and the estimation of each domain of sleep quality was based on the Likert scale from 0 to 3 scores, and higher scores mean worse quality of sleep. Physical activity of the participants was evaluated using the adapted Lithuanian version of the physical activity adult questionnaire, or suaugusių fizinio aktyvumo klausimynas. This questionnaire includes questions about the frequency, intensity, and the duration of different types of physical activity, for example, walking, workouts, running, cycling, and etc., which were performed upon the last 7 days. The definition of physical activity implies the activity which was performed at least 10 minutes without any breaks. The evaluation of this questionnaire is based on the directions of the Canadian Physical Activity Guidelines that physical activity of adult person should be not less than 150 minutes physical activity per week. And our results. The mean age of the participants was 60.9 years. The mean diabetes duration was 11.2 years. The mean glycated hemoglobin level was 8.9%, and the mean body mass index was 30.6 kilos per square meter. Of all the research participants, 24 patients, or 49%, had physical activity less than 150 minutes per week, and 25 patients, or 51%, had 150 or more minutes per week. And Patients with higher physical activity were of significantly younger age, shorter diabetes duration, and lower body mass index than those with lower physical activity. But there was no significant difference in glycated hemoglobin level. All the researched sleep quality domains were significantly better in patients with higher physical activity than in those with lower physical activity. And significant correlations were detected. Physical activity correlated negatively with subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, sleep disturbances, and use of sleeping medications. And our conclusions. Type 2 diabetes mellitus patients with higher physical activity have better sleep quality and lower body mass index than patients with lower physical activity, but not different glycated hemoglobin level. Duration of physical activity in type 2 diabetes mellitus patients is negatively related to subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, sleep disturbances, and use of sleeping medications. And here are our references. Thank you for your attention. Maybe you have some questions for me.
Thank you for the presentation. I would like to ask the jury if anyone has questions.
Yes, hello, Natalia. Thank you for your presentation. Very correctly explained methods of the project, and results were very well reflected. And I would like you to ask your opinion why it didn't have an impact of physical activity on glycolyzed hemoglobin. What is the reason? How do you think?
Yes, we thought about that, and maybe it is because of that that glycated hemoglobin depends not only on physical activity, but there are many factors that can impact the level of glycated hemoglobin too. For example, another type of lifestyle, alcohol consumption, how to say, the dietary problems. All of the and also as use of insulin and use of insulin or other medications for diabetes control, and maybe these factors can impact too, not only physical activity.
And did you have a possibility to measure yourself, your physical activity of the patients?
Sorry, would you?
Did you have a possibility to talk with the patient and to see how they do how they answer these questions, and how about physical activity and sleep disturbance? Did you participate in the survey by yourself?
Yes, of course. First of all, we prepared the questionnaires and tried to make them the more clear for patients. And we used. We also took part in the preparation of these questionnaires, and we went to patients and fulfilled with them together if they if something was not clear for them. And for many people, for example, if the person is not too young, and sometimes they don't understand some terms, and we need to explain them.
Thank you.
Thank you for your.
Again, thank you for the presentation, and let's move on to the next presentation, diabetes mellitus as a prognostic factor for a more severe course of COVID-19.
Hello, can you hear me?
Yes.
Okay, hello. So my name is Aleksandra Chałupnik and I'm from Medical University in Lublin. Today I would like to present my work entitled Diabetes mellitus as a prognostic factor for a more severe course of COVID-19. So the COVID-19 is a disease caused by the SARS-CoV-2 coronavirus, whose dangerous feature is its high transmission rate combined with a higher risk of death. Patients hospitalized with COVID-19 had a mortality risk that was nearly 3.5 times higher than those hospitalized with influenza. And since the beginning of the COVID-19 pandemic, there have been reports of a worse prognosis in patients infected with the SARS-CoV-2 coronavirus, who additionally suffer from diabetes, and that is why I decided to look for more information on this topic. The aim of the study is to show that the presence of diabetes in COVID-19 patients is a risk factor for increased mortality among these people. Here are some basic facts. So the incubation period of the virus is estimated to be between 2 and 14 days, and the SARS-CoV-2 infection induces mild symptoms in the initial stage for 2 weeks on average, but has the potential to develop into severe illness, including a systemic inflammatory response syndrome. Virus spreads primarily through droplets of saliva or discharge from the nose, and it's RNA virus. In human cells, the main entry receptor for SARS-CoV-2 is angiotensin-converting enzyme 2, which is highly expressed in lung alveolar cells, cardiac myocytes, and vascular endothelium. So first, I would like to discuss potential pathogenic mechanism in patients with diabetes mellitus and COVID-19. So in human monocytes, elevated glucose levels directly increases SARS-CoV-2 replication, and glycolysis sustains SARS-CoV-2 replication through the production of mitochondrial reactive oxygen species and activation of hypoxia-inducible factor 1 alpha. So that is why hyperglycemia might support viral proliferation. The most common post-mortem findings in the lungs of people with fatal COVID-19 are diffuse alveolar damage and inflammatory cell infiltration, and these findings indicate an inflammatory pathology in COVID-19. So that is why several mechanisms have been proposed by which virally induced inflammation increases insulin resistance. In coronavirus-induced pneumonia, inflammatory cells can infiltrate the lungs, leading to acute lung injury. And this large burden of inflammatory cells can affect the function of skeletal muscle and the liver, which are the major insulin-responsive organs. And they are responsible for the bulk of insulin-mediated glucose uptake. Patients with COVID-19 also exhibit elevation of over-inflammatory markers, such as the dimer, fibrinogen, interferon gamma, interleukin-6, or CRP. And this might contribute to an increased risk of microvascular complication originating from low-grade vascular inflammation in patients with underlying diabetes mellitus. Now I would like to present two observational studies. First one is called Coronado, and it's the largest published observational study specifically focused on the characteristics of diabetes patients hospitalized for COVID-19 infection, and it was designed to address three main objectives. So first, to characterize the phenotype of patients with diabetes hospitalized for COVID-19. Secondly, to determine the prevalence of poor prognosis, using a primary outcome combining death and tracheal intubation for mechanical ventilation within the first 7 days of hospital admission. And lastly, to identify any prognostic factors associated with early severity of COVID-19 in the specific inpatient diabetes population. So an intermediate analysis recently published in Diabetologia focused on 1,370 participants who were predominantly diabetes 2 patients. And the Coronado study confirmed that the severity of the prognosis for COVID-19 infection in people with diabetes, as 20% of the study population required tracheal intubation for mechanical ventilation, and the mortality rate was 10% as early as 7 days after admission. What is also interesting is the fact that having a history of vascular diabetes complication significantly increased the risk of death. The second study was performed at Tongji Hospital in Wuhan, China. A total of 198 patients were treated from January 10 to 24 February. And patients were admitted under the following inclusion criteria. They had to be over 18 years old, had laboratory confirmation of COVID-19 by real-time PCR, and chest computer tomography findings meeting the standard for diagnosis of COVID-19. Compared with patients with severe COVID-19 but without diabetes, patients with diabetes were more susceptible to receiving mechanical ventilation and admission to ICU. And also they had higher mortality. In addition, patients with severe COVID-19 with diabetes had higher levels of leukocyte count, neutrophil count, high sensitivity C-reaction protein, procalcitonin, ferritin, interleukin-2, 6, 8, the dimers, and fibrinogen. And finally, the Kaplan-Meier survival curve showed a trend towards poorer survival in patients with severe COVID-19 with diabetes than patients without diabetes. So as you can see, study results show that diabetes is one of the predictors for more severe course of COVID-19. The course of the disease in this group of patients is characterized by higher values of inflammatory markers and more advanced treatment. So in conclusion, patients with COVID-19 and coexisting diabetes require special attention because more often than in non-diabetic patients, severe complication can be observed. Thank you for your attention.
Thank you for the presentation. I would like to ask the jury if anyone has questions.
Hello, dear Alessandra, thank you for your presentation. I have a question. Why did you, I did find out that you was looking at 9 articles, but you choose just few to reflect us in more detail. Maybe you can explain this?
Why I choose this two observational studies. Being completely honest, I chose them because I think they were the most famous from all that was performed. And I think that I find like the most information about these two topics, and they looked them up. And I also didn't have time with presentation to show, I would say 10 observational studies. So I thought that these two are the most important to show. Mostly the Coronado study, because from what I heard, it's the biggest observation study that was performed in Europe. So I thought that this may be interesting.
Maybe in future it's useful to use like summarized tables, so we can put a lot of data in one slide, and it will save your time and it will be very interesting. And the second question would be, what are the keywords you're using to find the articles?
Can you repeat the question, because I didn't hear?
When you usually do a literature review, you need to have to put keywords in, for example, PubMed, to find the articles you need. So what were the keywords for your research?
It was diabetes mellitus, coronavirus, increased risk and mortality. Oh, and prognostic factors also.
And in total, you found 9 articles, yes? Or there were more?
I found more articles, but the 10 I chose was the most adequate, I would say.
So maybe in future you can do in your methodological section to put inclusion and exclusions criteria. So it will be very interesting also. Thank you very much.
Thank you.
I have also one short question. Thanks for this nice overview. I would like to ask you, what would be your practical recommendation for let's say patients, doctors, from what you have read, and what would you suggest us?
So I think the most basic, so I have like the most basic recommendation. So if doctor knows that the patients suffer from diabetes, and even if patients have mild symptoms, like they are not severe, only mild, I think it's kind of like doctors should control more patients, like more often, even if like symptoms are mild. He still should control him, I don't know, maybe once, maybe 2 times in a week. Like he don't have to look, he can call to him, like to patients, because right now I think phone visits are more often than like patients with like doctor face to face. So just like, I think they just should control patients more often, and this is like the key to control patients. I don't know.
Again, thank you for the presentation, and let's move on to the next presentation, the quality of pain management in wheelchair patients.
Hello, do you hear me well?
Yes.
Right, so I'm sharing my screen in a while. Okay. So hello, my name is Alexandra Guadis, and I am representing my student scientific group of the Department of Oncology and Radiotherapy at the Medical University of Silesia in Katowice, which is in Poland. And I am very happy to speak to you today, even if I cannot be in Lithuania right now. I'm still very glad to take part in this event. And today I'd like to begin a discussion on pain in oncology and produce the results of research conducted by me and my colleagues on the quality of pain management in adult patients with cancer. So there are numerous definitions of pain, including the one presented on the slide, but what they have in common is that they focus on a subjective experience of a patient, and this perception will later indicate what we call an adequate pain management. Pain is a major experience of cancer patient, and often it's the reason why we start with diagnostic procedures. It is associated with the disease itself, but also it may be a result of anti-cancer treatment. So And it can be acute and chronic. And I'd like you to remember that all pain should be addressed and treated. We cannot tell the patient that it's normal and they should live with it, because the quality of pain management not only affects the quality of their lives, but also their attitude towards further anti-cancer treatment we'd like to offer. So pain management should be an integral part of oncological therapy. There are many methods of pain management. I chose 3 to focus on. Pharmacotherapy, no doubt the most popular way of dealing with cancer pain, but also physical therapy and interventional methods. And in pharmacotherapy, we have specific guidelines on how to use drugs in pain management. I won't describe them. I just wanted to give you the picture of the variety of methods that can be used. But that's the theory and what we wanted to know, and that's why we started our study. We wanted to know what is the quality of pain management our patients are receiving. We wanted to know if they are satisfied with their pain treatment and what factors affect their perception of pain. So we created a questionnaire, and together with my team, we surveyed 194 patients from 2 oncological departments of our home university in Katowice. And we assisted our patients while filling the forms, so they could always ask us for clarification. And we asked about their medical history and the perception of pain, of course, but we included both very specific questions, such as the one where patients assess their pain in 0 to 10 scale, where 0 is the lack of pain and 10 is the worst pain one can imagine. But also we included open questions, as we believe is the right way to do in the study of someone's perception. And the demographics of our participants corresponded to overall statistic of cancer patients in Poland. So we had almost 1-to-1 gender ratio, a median age of 65, and our patients had usually gastrointestinal, breast, and lung cancer. Almost 40% declared the presence of pain, and among those who declared it, the pain was usually mild or moderate, with the median value of 3 in this 0 to 10 numerical rating scale. And we didn't find any difference for gender, tumor location, or clinical stage, both in the incidence and in severity of pain. And 37% of all patients declared that they had a pain treatment. And we found a link between the perception of pain and mood deterioration and the quality of life impairment. So about 68% of patients stated that the pain causes a low mood or negative emotions in them. And it was more often in patients with moderate and severe pain. And we found we observed very similar thing, a very similar link between pain and impairment of daily routines. Most commonly, the treatment was prescribed by urologists, but also family doctor, palliative care or hospice doctor, and in specialistic pain care clinics. And we weren't surprised when we realized it was mostly pharmacotherapy in 96% of cases, but also invasive procedures and physical therapy. And answering the most important questions of our study, if our patients are satisfied with their pain management, yes, they are. 73% of patients stated it was optimal, but we asked one more tricky question. We asked, do you want to make changes in current therapy or start one, yes or no? And there was a much difference between those on the pain therapy and those without, statistically significant. Those on pain therapy usually wanted to make changes, and those without usually didn't want to start one. So we think that it may be an indicator of undertreatment or of the fact that the therapy may not be personalized enough. So here are the conclusions that we've made. First, they may be a link between low mood and the perception of pain. And then our patients received therapy for their pain, and this therapy improved the quality of their lives. And these two are what we are really glad to know. But our results suggest that some patients may be undertreated. And we have many methods of how we can deal with cancer pain, so we should use them to provide more personalized therapy. Thank you. And if you have any questions, I'll be glad to answer them.
Thank you for the presentation. I would like to ask the jury if anyone has questions.
Hello, thank you for the nice presentation. I have one question, and I want to ask, did you look at the reasons why so many patients were not receiving the therapy for pain syndrome, if they had it? Well, why was such a small proportion of patients receiving this? What was the reason? So this is the first question, and the second question is, did you look at the types of medical pain therapies that the patients were receiving, and then did there is an increased use of cannabis preparations among the cancer patients? And I just wanted to ask if this is available in your country, and if any of them were using such therapy. So thank you very much.
So first one, if I understood correctly, you asked why such a small proportion of patients received the therapy. Well, 40% of all our patients stated that they had cancer pain, and 37% declared that they had therapy. They weren't exactly the same people, because there are a few people who stated that they don't, that they feel pain, and vice versa. But I think it's somehow corresponding. And the second one, actually, we asked two questions about medical cannabinoids in our survey. One was, do you know that there is a possibility of using it in cancer pain? And about 14 of our participants stated that they know that this kind of treatment exists, and 2 of them ticked that they use it. And actually, it is legal in Poland to use medical cannabinoids and prescribed by oncologists or some other doctor, but it's quite expensive. And from my knowledge, I think that some patients just have medical marijuana, but from illegal sources, and they weren't really eager to admit that in this survey. Even it's anonymous. Because we had direct feedback, because we assisted our patients by filling the form. So I once got the answer that one patient didn't want to take it because he was afraid that I will say to somebody. So I don't know if he took it or not, because I wasn't checked by patients. But I think that it is method limitation. So I'm not sure about those results, if they are accurate.
Thank you.
Hello, Alexander. I am very happy that you are so excited about what you are doing, and keep forward, don't stop. And one important message maybe for your future research, it is obvious that the mood deterioration was very important for those patients in pain. And do you think that mental health care treatment, if needed, should be incorporated in pain management, pain control?
I'm sorry, but I think I didn't hear you well. What type of treatment?
Mental health, maybe to evaluate mental health if the patients don't have mental health problems, and if they do, maybe we can recommend some psychologists or psychiatrists to involve in pain control. Would be it that valuable or not?
Well, I think it would be very valuable to include it in the survey. But from my experience and from my knowledge, it's not very popular in Poland. Psycho-oncology is not really a thing which is, but it is growing actually. And I think from our study, we cannot actually know which way it goes. If the low mood affects the perception, or that the people with pain actually have low mood. So I think that we should assess it more carefully, and maybe ask some psychiatrists or psychologists to evaluate our survey in the future. We could continue this type of. Thank you for your question.
Thank you. Go forward.
Again, thank you for the presentation, and let's move on to the next presentation of the session, the impact of socio-demographic and clinical factors on the lifetime of voice prosthesis.
Hello, we cannot hear you.
Okay, maybe let's move on to the next presentation, the regulatory role of microRNAs in intestinal epithelial barrier in inflammatory bowel disease.
Hello, are you hear me?
Yes.
Yes, I'm so sorry for my late, but I tried to upload the presentation. The presentation is visible now, yes?
Yes, we can see you and hear you.
Okay, thank you very much. So good morning, ladies and gentlemen. Thank you so much for having me today. My name is Blaise Okment, and I am from Medical University of Silesia in Katowice, Poland. I would like to take this opportunity to talk to you about the regulatory role of microRNA in intestinal epithelial barrier in inflammatory bowel disease. The scientific problem figure in my presentation appears to be focused on complex molecular issue underlying the disease. It is. So I will tell about pathogenesis and pathophysiology of inflammatory bowel disease with great attention taken to the role of intestinal epithelial barrier in health or disease. Then I will tell about microRNAs and further about aims, methods, results, and conclusion of the review. So let's start the presentation and let's go to the introduction. Inflammatory bowel disease is an immune-mediated chronic idiopathic inflammatory disorders of the tract that encompass disease and ulcerative colitis. And what is important, the pathogenesis mechanism of IBD is still not fully elucidated. I would like to illustrate this point by showing you figure number 1. In the pathogenesis of IBD may involve uncontrolled inflammation, altered composition of the microbiome, certain environment and genetic factors, immune response dysregulation, and of course, intestinal barrier disruption. Intestinal epithelial barrier consists of a single layer of epithelial cells connected by multiple junctions, including tight junctions, which are essential complexes that forming a continuous sealed space of intestinal epithelial barrier, guarding its proper function. intestinal epithelial barrier exactly act as a physical barrier between the luminal components and underlying tissue, limiting access of the microbes, antigens, and toxin to the internal environment. Figure number 2 illustrates the proper function of intestinal epithelial barrier on the left side, and on the right side, dysregulation of intestinal epithelial barrier function. Loss of the intestinal epithelial barrier function, such as increased permeability or impaired integrity, combined with an aberrant immune response, is significantly involved in the development of inflammatory bowel disease. Intestinal epithelial barrier function could be modified by many molecules, including microRNAs. MicroRNAs belong to non-coding and non-messenger single-stranded RNAs, which are endogenously expressed, and by silence target mRNAs, they modulate gene expression, as it is illustrated at figure number 3. Now let's move to the aims. The aim of the study is to gather in and evaluate the most recent publication on the topic, to create a new complex explanation of pathogenesis and create a new therapeutic possibilities in inflammatory bowel disease. We based on the literature for the last 5 years, search using PubMed with eligibility criteria as described. The most important criterion for us, it was significant changes of intestinal barrier integrity caused by microRNAs. Why? I will if you look at the table 1, you can see gathered results of our review. Many microRNAs interact with multiple signaling pathways dysregulated in the course of inflammatory bowel disease, associated with inflammation, immune response, and the structure of intestinal barrier. Alterations of all these processes contributes to significant changes in expression of tight junctions proteins, leading to the intestinal barrier disruption. All of studies selected by us investigate the influence of inhibition or stimulation by proper microRNA depending on microRNA's function. I would like to illustrate this by showing you figure number 4. In the left cell, we can see molecular mechanism of intestinal epithelial barrier disruption caused by altered microRNA's expression. In the right cell, you can see effect with inhibitors or mimics of proper microRNAs. That treatment trials in murine colitis model and chance of intestinal barrier function and reduction of intestinal damage. And this might be the innovation and new hope for patients because heterogeneity in the clinical course of both CD cause difficulties in the matching the greatest therapeutic way for all patients, and unfortunately majority of patients must undergo surgery. Concluding, microRNAs play important role in the pathogenesis of IBD as provokers of the inflammation and many other alterations responsible for negative effects on tight junctions proteins expression and intestinal epithelial barrier function. Potential benefits from microRNA-based therapy you can see at figure number 5. Discussed molecular effect of microRNA and fever surgical interventions, maintain the remission of the disease, better clinical outcomes, eventually causing better life quality. Therefore, therapy based on target and regenerate intestinal epithelial barrier may be a promising therapeutic goal. And And to finish my presentation and start the discussion, I want to say that this will be a really long way to gain breakthrough in IBD therapy by microRNA therapeutic. However, currently lasting clinical trials with microRNA-based therapeutics revealed positive feedbacks on their potential in HIV infection. So the future is upon us. Thank you very much for your attention. I will be happy to answer your questions now.
Thank you for the presentation. I would like to ask the jury if anyone has questions.
Yes, thank you very much for this nice overview. Since we are also working a lot with microRNAs, I would like to ask a couple of questions. So first of all, what do you think is the reason that in the different studies we see that the same microRNAs are deregulated in different directions? So in some studies they're upregulated and some are downregulated, the same microRNAs. So this is one question. The second question is related to the biological function of microRNAs, because they're in specific, and the same microRNA targets multiple genes. Sometimes it's several hundreds of genes. So when thinking of this therapy, do you think this is a specific enough molecule to potentially treat the IBD and also other autoimmune diseases? So thank you.
I want to ask the first question first. I think that the most important thing is the proper method, because a lot of studies used only PCR methods. Yes, and in my department we start using mirase method, and this is totally different. And I think that that this is the cause. This is the reason for these differences in the expression of microRNA. And of course, when we're using cell cultures, when we use these tissues of altered tissue in many diseases, all very important examine a proper function of microRNAs. Yes, that's it, and I think that this is the reason, and this interaction is really complex to investigate, because as you said, doctor, many microRNAs interact with many genes. One microRNA can bind 2 or 3 on many gen, because this fragment which is bound by microRNAs, 5 UTR fragment, yeah, this needs to be 100% complementary to one microRNA to mRNA, and this is the reason why we gained results on expression one, altered expression by increased or decreased expression of proper microRNAs.
I would like just to congratulate you that you are really deep in your topic. No, you don't go in superficial way. And I really liked your summarized figure number 5. And it was very clear. So also keep going, and thank you very much.
Thank you very much.
Again, thank you for the presentation, and let's move on to the last presentation of this session, the impact of socio-demographic and clinical factors on the lifetime of voice prosthesis.
Okay, so first of all, can you hear me now?
Yes.
Oh, thank God. Okay, can you see my slides? Okay, so I will be talking about the impact of socio-demographic and clinical factors on the lifetime of voice prosthesis. My co-authors of this work were Gabija Gauča and medical doctor of Department of Otolaryngology, Kipras Pribušis. Total laryngectomy impacts essential functions such as breathing, communication, and swallowing. Voice prosthesis is a current gold standard for a voice rehabilitation after total laryngectomy. The device lifetime is a determining factor in patient quality of life and readmission rates. It could last from a few months to a few years. However, it's usually the shorter time, and patients suffer greatly because they have to come back for the prosthesis replacement quite often. The procedure is unpleasant, and also the traveling expenses adds up. That's why it's necessary to determine prosthesis longevity affecting factors for better healthcare planning and voice rehabilitation. So how does the prosthesis work? Well, the prosthesis is placed between the trachea and the esophagus. When the tracheostomy is occluded with a finger by a patient, the air coming from the lungs is redirected through the voice prosthesis one-way valve into the cervical esophagus. Then the musculature of the segment goes into vibration. The air is resonated by vocal tract and shaped into intelligible speech by the articulating muscles. So the aim of our study was to evaluate the impact of age, sex, place of residence, neck radiation, gastroesophageal reflux disease, and the use of heat and moist exchanger on the lifetime of voice prosthesis. So we conducted a retrospective cohort study of patients who underwent total laryngectomy followed by secondary voice prosthesis implantation in Lithuanian University of Health Sciences Kaunas Clinics and Kaunas Clinics Affiliate Hospital of Oncology. We collected data including age, sex, place of residence, documented neck radiation, GERD, and use of HME. We also divided patients into subgroups for comparison, such as place of residence was divided into urban area and rural area of living, and patients' age was divided into patients under 65 and over 65 years old. The main outcome measure of the study was the lifetime of voice prosthesis measured in days, from the day of insertion to the day of removal. The statistical analysis was performed using students' t-test for comparison of means and Kaplan-Meier survival analysis for device lifetime. So our sample was distributed normally and no outliers were detected. And our results were these. A total of 322 voice prostheses were used for 59 patients. The mean lifetime of voice prosthesis was 184 days. Voice prosthesis lifetime was significantly longer in the Asian group rather than the younger group, mean 211 days versus 176 days. We also found that prosthesis lifetime was significantly longer in male group compared to female group, mean 192 days versus 138 days. The place of residence had a statistically significant impact comparing rural areas with mean 189 days and urban areas with mean 182 days. For patients who received radiotherapy, the device lasted significantly longer compared to those who did not, mean 191 days versus 151 days. Significantly longer device lifetime was seen in patients without GERD compared to those with documented GERD, 185 versus 182 days. For patients who used heat and moist exchanger, the device lasted significantly longer compared to those who did not, mean 213 days versus 179 days. So to conclude, older age, male sex, rural living area, neck irradiation, no presence of gastroesophageal reflux disease, and the use of heat and moist exchanger had a statistically significant impact in prolonging the lifetime of voice prosthesis. Thank you for your attention. Do you have any questions?
Thank you for the presentation. I would like to ask the jury if anyone has questions.
Hello, thank you for a nice presentation. I have one short question. If I got it correctly, how could you explain that older age is associated with better outcomes, longer activity of this prosthesis? So how could you explain this? Thank you.
Yes, we saw that older patients have a higher tolerance for minor health issues, and they sometimes wait longer to come to change the prosthesis just because it's uncomfortable for them, and they wait to schedule an appointment, and so this could have affected these results.
Okay, thank you.
Thank you, Gabia. And did you have a chance to talk with these patients, to communicate with them during the study?
No, sorry, this was a retrospective study, so we just analyzed the case histories. So we didn't have a chance, but I hope I will have that in future.
Mm-hmm. And do you think the social part would be important here? Like if a patient lives alone or has another risk factors, so something like alcohol consumption or etc.?
Yes, I do believe that, because most of the patients are of lower socioeconomic group. They have this laryngeal cancer because of alcohol consumption, smoking, and they usually don't take care of themselves so highly. So yes, I do believe that has an impact.
Thank you. Good luck.
I would like to thank all of presenters for their delightful presentations. Let's take 10-minute break while all the scores are counted. Right after the break, we will announce the winners of the session. I would like to thank the jury for their work today. Thus, after counting all of the jury points, I'm delighted to announce that the winner of this session is Alexandra Gladish and her presentation of the quality of pain management in adult cancer patients. Congratulations, and we will contact you later. So, the internal medicine session part 1 has finished. I would like to thank all the participants for attending the 5th International Health Science Conference. Hopefully it was useful, and now I invite you to join the rest of the conference and the keynote speakers, Dr. Skontas Kriaučionis and Dr. Kevin Tracy. Thank you for your interest in science and have a good day.